Hello, I'm Dr. Mas Chapanda, Clinical Research Fellow at the University of Liverpool. I'm going to give a series of lectures on infectious diseases for the MRCP Part 2. The first lot of lectures deal with HIV and immunosuppression. Let's go to question number 1. An HIV-positive patient with a CD4 count of 80 presents with hilar and abdominal lymphadenopathy. He also has pulmonary infiltrates and his hemoglobin is 8. Which of the following diagnoses correlates most closely with the above presentation? I'll give you a while to consider these options. There's really only one answer there which correlates closely, and this is Mycobacterium avium intracellulare. So Mycobacterium avium is very similar to Mycobacterium tuberculosis. However, the difference is that it affects both abdominal and pulmonary sites at the same time with pulmonary infiltrates and is associated with a low hemoglobin. It is also associated with chronic diarrhea and a low CD4 count. That's what makes this the most relevant. Pneumocystis jirovecii would hardly affect the abdomen. Cryptococcus really is the brain, and Mycobacterium tuberculosis is mainly the chest, but that can also have abdominal presentation. Let's look at other causes of chronic diarrhea in HIV. The first and most common presentation is with Cryptosporidium. This will present with profuse diarrhea. Others to consider are Isospori belli as well as Microsporidia. And then there you have Mycobacterium avium intracellulare. The treatment for MAI is antituberculous drugs such as rifabutin, as well as azithromycin and ciprofloxacillin. In addition, for prophylaxis, azithromycin is used where the patient does not have active disease but has a low CD4 count. Let's now consider question number 2. A 33-year-old Somali woman presents with a 1-month history of increasing lethargy and confusion, and she was brought to the emergency department by her husband. He said she has been deteriorating gradually and now needed help with dressing. Her speech had become slurred and she has fallen 3 times in the last week. She had complained of generalized headache during the last week and also nausea and anorexia. They have been in the UK for 4 years. She had no weight loss, fever or night sweats, and no cough, arthralgia or rash. She's a type 2 diabetic and is on a biguanide and also takes the oral contraceptive pill. She lived with her husband and 2 children, all of whom were well, in a council flat. On examination, she is drowsy and has a GCS of 14 out of 15. Her temperature is 38.3. She has no lymphadenopathy or rash, but her neck is a little stiff. Her heart, lungs, and abdominal examinations are all normal. Her cranial nerves are symmetrical, but she will not permit you to attempt ophthalmoscopy. Her left side appears to be increased in tone compared to the right side and is slightly weaker. CT head without contrast shows bilateral hypodense lesions in the periventricular region. Let's look at the results from the lumbar puncture. Her opening pressure is normal. Her glucose 4.1, protein 0.7, with a white cell count of 5, which is normal. If you look at a peripheral blood, you will see that the blood glucose is 7.8, with slightly raised ALP. CRP is raised at 101, and the rest of the markers there appear normal. So, what is the most likely diagnosis? And here are 5 options for you to consider. This is a difficult one. I think the clue is that the gradual process in which her symptoms have developed. That gradual process can only suggest progressive multifocal leukoencephalopathy. Indeed, cryptococcal meningitis could present with a more gradual insidious onset. However, you'd find abnormal presentation in the CSF, which in this case appears to be normal. She has HIV, and the most likely is HIV-associated dementia. HIV dementia has to be differentiated from PML, which is progressive multifocal leukoencephalopathy. PML will present with more specific neurological deficits, which is what we're seeing in this lady, and it's progressive with time. Unfortunately, regardless of highly active antiretroviral treatment, once this process has begun, it does not end and the patient will die. Now, PML, and I'll show you on the next slide, can be seen on a CT scan as hypodense lesions, but when we look at the MRI, T2 weighted, you will see areas which light up, and this is evidence of involvement of the oligodendrocytes in the white matter. They are affected and infected by the JC virus. Diagnosis can be difficult, but easily supported by an MRI. CSF sometimes can be culture positive for the JC virus. There is no specific treatment. Cidofovir has been tried with variable success, but the advent of HAART has seen, fortunately, lessening of this condition. And so the recommendation now is to start highly active antiretroviral treatment early before the disease has begun. Let us now consider question 3. A 30-year-old freelance journalist presents with a dry cough and weight loss. He recently returned from a sabbatical in Thailand. Shortly after arriving back to the UK, he developed chickenpox. He saw his GP, who felt it had affected his lungs, but now 6 weeks after the infection has cleared, he still complains of breathlessness and fevers. He used to be able to run for several miles, but now he can only walk briskly for 30 to 40 meters before becoming breathless. 4 months ago, he had glandular fever in Thailand. Otherwise, he has no past medical history of note. He takes no regular medication but is allergic to co-trimoxazole. He's an ex-smoker, having stopped smoking when he was diagnosed with the chickenpox. On examination, he has a temperature of 38.2, his blood pressure is 130/80, pulse of 128. ECG shows sinus tachycardia, and oxygen saturation are 98% on air. Respiratory examination reveals a wheeze on the right lower zones. The rest of the examination is normal. On examination of skin, there are scars from chickenpox and florid molluscum contagiosum on the trunk. What is the most likely diagnosis? Here are 5 options for you to consider. I think this question is straightforward. He has Pneumocystis carinii infection. Pneumocystis carinii has been renamed to Pneumocystis girovecii. Carinii is what rats get and girovecii is what humans get. I think the clues here are his insidious onset of breathlessness, which was first thought to be chickenpox pneumonitis, and clearly after the chickenpox had cleared, it was still there. Next is the low saturation, which will be more evident if you desaturate the patient on walking. So you would challenge the patient by making him walk up and down the corridor and then check for the saturations. That is more indicative of PCP. PCP treatment, the mainstay of treatment, is co-trimoxazole. Unfortunately, in this gentleman, we are told that he is allergic to co-trimoxazole. We would not recommend challenging him with co-trimoxazole. The options that are therefore left for us, you could use clindamycin in the treatment for PCP, or you could also use IV pentamidine. Pentamidine nebulized is not an option for treatment. That is used as prophylaxis. Dapsone as well is used as prophylaxis. So really the options for him are clindamycin or pentamidine IV. Let us look at that X-ray more closely on the next slide. So you will see that classic bat wing appearance, which might look like heart failure, but if you look at the bases, you will see that the bases have been spared in this patient and therefore is not like heart failure. And this is a very typical appearance of infiltrates that are PCP. Now let us consider question number 4. A 32-year-old woman presents with fever and a sore throat 3 weeks after returning to the UK from a 4-week holiday in Kenya. While in Kenya, she did swim in freshwater lakes. She had a number of mosquito bites on her legs, and she admits to trekking in the jungle for at least a week. Examination reveals a temperature of 39 degrees. There was evidence of pharyngitis and a diffuse erythematous rash on the trunk. There was axillary lymphadenopathy. Blood results are as follows, and you can see there that they are essentially normal. Thin film, there was no malaria parasites to be seen. Blood cultures, no growth, and throat swab, no growth. What is the most likely diagnosis? And here are 5 options to consider. This is a very difficult question. You would expect most people to choose falciparum malaria. They tell us that the blood film is negative, but we know from the MRCP exam that that doesn't necessarily mean malaria is negative. However, if we look, her platelets are normal. Again, with malaria, you'd expect there to be low platelets, and you do not expect pharyngitis to go with malaria. Dengue fever, again, the history is a bit long from her return, and again, pharyngitis is not usually a feature of this. So we're left with infectious mononucleosis, toxoplasma, but actually HIV infection is what she has. And this points out the importance in a history of taking a thorough sexual history. This is a seroconversion illness from HIV and would be typified by a meningitis, which can be an aseptic meningitis, a pharyngitis, fever, and this rash, which is very similar to infectious mononucleosis. Let's consider question number 5. A 42-year-old gay man presents for review with sudden loss of vision in his left eye. He has a past history of hypertension, but appears otherwise well. Fundoscopy reveals extensive hemorrhages and exudates. Blood tests reveal a CD4 count of 85. Which of the following represents the best initial treatment in this case? And you will see there an example of a slide looking into his eyes of what you would see in a gentleman who is HIV positive, presenting with sudden loss of vision and a low CD4 count. Let us consider these options in his treatment. The answer here is IV ganciclovir because he has CMV retinitis. And the only drug there that can be used for the treatment of CMV is ganciclovir. Other drugs that could be considered would be foscarnet, and also possibly you could use cidofovir. Acyclovir is used for herpes simplex and has no role in the treatment of CMV retinitis. A few things to mention about CMV. It happens in HIV patients when they have very low CD4 counts, less than 100, like in this gentleman. The typical appearance, which is described, or sometimes you would be given the slide, is this pattern of hemorrhage and exudates, which is cottage cheese and tomato ketchup. That's the typical MRCP description of what you would see in the eye. And then the treatment is with IV ganciclovir, remembering that ganciclovir can cause marrow suppression, and therefore you have to keep a close eye on the full blood count. If it was foscarnet that we were using in his treatment, remember that foscarnet can cause nephrotoxicity, and so in those patients you have to keep a close eye on their eGFR and on their renal function. And now for question number 6. A 24-year-old man known to be HIV positive presents with a 3-day history of worsening shortness of breath. He also has fevers and a cough productive of green sputum. His last CD4 count 2 months ago was 220, and he is on no treatment. On examination, O2 saturation is 91% on room air, temperature of 38.8, pulse 120, and there are crackles that are heard in both mid-zones. Chest X-ray shows diffuse interstitial shadowing bilaterally. Blood gas is on air, he's hypoxic, with a normal bicarbonate and a saturation of 90%. What is the most appropriate initial treatment for this gentleman? And here are 5 options to consider in his treatment. This question is pretty straightforward. This gentleman has an acute pneumonia, which is a community-acquired pneumonia. From the description that it is bilateral, this would suggest that it's an atypical pneumonia, and therefore you would have to use clarithromycin in the treatment. So treatment would be amoxicillin and clarithromycin. The history is too short for this to be PCP. If it had been PCP, you'd have considered option A, which is co-trimoxazole. Remembering that option C is the alternative treatment for PCP if someone is co-trimoxazole allergic. Liposomal amphotericin is used to treat fungal infections, especially cryptococcal meningitis. Metronidazole treats anaerobes and would not be able to treat an atypical pneumonia. Remembering that HIV patients are allowed, like anyone else, to have atypical pneumonias. except for the fact that in HIV, they are more likely to get bacterial infections, as well as these other opportunistic, weird, and wonderful infections. Of note to discuss in this gentleman is that his CD4 count is 220. The current guidelines, and they keep changing, is to initiate treatment with highly active antiretroviral treatment when your CD4 count reaches 350. So he qualifies for that, and especially having a bacterial infection, a severe bacterial infection, he qualifies even more for the commencement of highly active antiretroviral treatment. Let's now go to question number 7. A 36-year-old Ghanaian man presents to the sexual health clinic for a routine screen. He moved from Ghana 2 months ago and has no previous medical problems. He is found to be HIV positive with a CD4 count of 40 and a viral load of 25,000. His toxoplasma immunoglobulin is positive. His IgM is negative. The cryptococcal antigen is also negative. He is referred to the HIV clinic where he is commenced on low-dose co-trimoxazole and highly active antiretroviral treatment, which is tenofovir, lamivudine, abbreviated as 3TC, and efavirenz. 3 weeks later, he presents extremely unwell with 5 kilogram weight loss, drenching night sweats, and malaise. What is the most likely diagnosis from these options here? This is a very difficult question if you haven't come across the term immune reconstitution syndrome. In essence, he has started antiretroviral treatment with a very low CD4 count. 3 weeks into treatment, he now comes in with weight loss and night sweats. It is not a drug side effect, so that excludes option number A, which is adverse drug reaction. It also takes away option number C, drug reaction to highly active antiretroviral illness. So what he is left with could be tuberculosis, could be non-Hodgkin's lymphoma or cryptococcus. But if you look at the timing, he is on HAART, and 3 to 6 weeks into treatment, he has developed this. This is very typical of the immune reconstitution syndrome. It is thought that as your CD4 count rises, your own body starts to recognize pathogens which were there but unrecognized by lack of an immune system. So once your immune system kicks in, you then start reacting to most likely tuberculosis in this case. In this gentleman who has night sweats, I would start tuberculosis treatment while still investigating for non-Hodgkin's lymphoma, etc. The treatment for immune reconstitution syndrome, continue HAART, treat specifically whichever one of the opportunistic infection has come up, for example, tuberculosis, CMV, but sometimes none of these will be present and you may have to start steroids for a limited period of time. And that's how you would address immune reconstitution syndrome. Let's consider question number 8. A 32-year-old man presents to the emergency department. He is known to be HIV positive but has been non-compliant with his treatment. His CD4 count is low at 80. He complains of a 3-week history of worsening headache and malaise. He reports symptoms of a dry cough and breathlessness a month ago, but this seems to have improved with antibiotics from his GP. On examination, he is unwell. He is febrile, tachycardic, with a blood pressure of 100/50, with SATs of 98% on air. There is no lymphadenopathy, but evidence of oral candidiasis. The chest is clear, cardiovascular examination is normal. On neurological examination, there is no focal neurology. He has, however, got marked neck stiffness and photophobia. CT scan of the head reveals no focal lesions. If you look at the CSF results, you will see he has an opening pressure which is quite high at 40 centimeters of water. Protein is 3.5, glucose is a little bit low at 3.1, with a white cell count of 45, the majority of which are lymphocytes. What is the most likely diagnosis in this case? And what test is most likely to give that diagnosis? Consider these options here. This gentleman has cryptococcal meningitis. He has a gradual onset of a headache. He has, in addition to the headache, no focal neurology and a very high opening pressure. Ziehl-Neelsen stain is negative and his CSF is negative for herpes simplex virus and gram stain, which is likely to leave only cryptococcal meningitis. The options that we're left with on the CSF is either to do an antigen or an India ink stain on the CSF. This is cryptococcal meningitis, and the treatment for it would be to start antifungal with high-dose amphotericin. You can use liposomal amphotericin because that is more lipophilic and crosses the blood-brain barrier. After 3 weeks, you can then change to fluconazole, which can be given orally. In addition, because of the headache and the high intracranial pressure, as evidenced from the lumbar puncture with an opening pressure of 40, he might need serial lumbar punctures as therapeutic to remove some of that pressure. If we look at the slide, you will see an example there of an India ink stain. What this shows is the Cryptococcus, which is a fungus with the typical Mexican hat appearance with the dark background of India ink. And this is an example of the Cryptococcus, which should be treated with liposomal amphotericin B for fungal treatment. The treatment is given for 3 weeks initially with amphotericin and then extended with fluconazole. Let's now look at question number 9. You are the medical senior house officer on call. A 40-year-old man presents to the emergency department with jaundice. He gives a week-long history of worsening jaundice with associated nausea and malaise. There is no change in bowel habits and no abdominal pain, so this is painless jaundice. He has felt unwell for the past 3 weeks, but initially his symptoms were more flu-like with muscle aches and fever. He is a gay man and reports multiple sexual partners in the past 3 months. He often has unprotected anal intercourse, both passive and active. He uses ecstasy and cocaine as recreational drugs. He used to occasionally inject drugs, but has not done this for over 10 years. He regularly attends the GUM clinic for sexual health screens, and his last HIV test was negative 6 months ago. On examination, he is febrile, he has a pulse of 95, he is deeply jaundiced, the abdomen is soft with very mild tenderness in the right upper quadrant. There is no organomegaly. Let's look at some of his blood tests. You will see here a normal white cell count, normal platelet counts. His bilirubin is markedly elevated, and we've been told that he is jaundiced. His ALT and his ALP are both elevated. His albumin is 30, and his Hep B surface antibody, that surface antibody is positive, but surface antigen is negative. His renal function is normal. What test is most likely to give the diagnosis? Consider these 5 options here. This is a very difficult question. The answer to this is hepatitis A antibody testing. Liver ultrasound wouldn't really tell you a diagnosis in this case. We know that he has an obstructive jaundice, and if he had gallstones, for example, then it might help. But this is not the case of gallstones. Hepatitis C, we're told that he has regular screens and he hasn't injected drugs for over 10 years, so it's not going to be Hep C. The transmission of Hep C with intravenous use is probably the highest mode of transmission. Through sexual intercourse, there's very little transmission. Anti-Hep D testing is going to be useless in this case. Hep D goes with Hep B, and from that serology, you will see that his Hep B surface antigen is negative. That means he does not have hepatitis B. His antibody being positive just says he has previously had it before. HIV test in this case is pretty useless. HIV being positive or negative doesn't tell you what is the cause of the hepatitis. However, this gentleman has hepatitis A. The mode of transmission of hepatitis A is fecal-oral, so it's usually through food poisoning. However, we're told that he has anal intercourse, and we know that through fecal-oral contact that way, one can transmit hepatitis A, and therefore hepatitis A antibody testing would be relevant. Again, here we have to separate the antibody into 2. You would want to look at hepatitis A IgM for acute infections and hepatitis IgG for previous infections. I would suspect that in this gentleman, his Hep A IgM would be strongly positive for acute presentation of Hep A, which can present with both abnormal ALT as well as abnormal ALP and gamma GT. Let's consider the last question. A 27-year-old man presents to the emergency department feeling generally unwell. He has a sore throat and feels feverish. He has noticed some mouth ulcers and a skin rash that has developed over the past 4 days. He is gay and has not had sexual intercourse for the past 6 months following treatment for syphilis, until a week previously when he had unprotected sex with several partners whilst using recreational drugs. On examination, he has fever of 39 degrees, he's tachycardic and has a normal blood pressure. He has a maculopapular rash over his whole body, particularly over his trunk and involving the palms of his hand and the soles of his feet. He has some small cervical nodes and his pharynx is red. On his buccal mucosa, there are several small ulcers. Which is the most important test to do now? And here are 5 options to consider. Again, a very tricky question. Someone presenting with rash soon after sexual intercourse. The answer here is an HIV viral load. An HIV IgG antibody test, which we call the HIV test, would be negative. It would be too early. Remember that you would be in the window period for at least 3 months. And he is within the first 3 months, so HIV antibody test would be negative. TPHA would be misleading if you're thinking of syphilis, which is something you would consider in someone with a rash, especially presenting on his palms. His TPHA would be positive because he has previously had syphilis, and so this test is not going to add or inform you of syphilis. It is reasonable to think that he has HSV in his mouth, and a throat swab might be useful, but actually you would go ahead and treat for HSV if you thought that was what it was. An HIV viral load is most important in this case. It's not used usually as a diagnostic test or as a screening test, but in this case where you think someone is in the window period, they're going through a seroconversion illness, then their HIV viral load is likely to be very high. And so that would be the most important test in this case. You would find a viral load probably greater than 1,000, most likely close to 1,000,000 if they're going through an HIV seroconversion illness. When someone presents with primary HIV, which is a seroconversion illness, and they're unwell with it, there are grounds to start antiretroviral treatment then. As I mentioned earlier, we would consider HIV treatment if your CD4 count had dropped to 350. However, regardless of CD4 count, if you have a symptomatic primary HIV, one would go and do viral load testing. Thank you.